I am Dr. Deepak Chaudhary, Principal Director and Head, Arthroscopy and Sports Medicine Department at BLK Max Hospital.
Today I'll be speaking on double bundle ACL reconstruction. We all know orthopedics is all about restoration of anatomy, and arthroscopic ACL reconstruction is no exception to this rule. We all know that ACL is composed of two separate bundles, the anteromedial bundle and the posterolateral bundle. Not only are these two bundles anatomically distinct, but they have two different functions. The anteromedial bundle primarily controls the anteroposterior mobility of the tibia under the femur, and the PL bundle is primarily responsible for rotational stability. So when we reconstruct the ACL, it is important that we restore the anatomy as well as the normal functions and the kinematics of the knee joint. So with this background in mind, the double bundle ACL concept came into existence in early 2000, and since then we have been doing the double bundle ACL reconstructions. So what are the advantages of an anatomical ACL reconstruction? So anatomical ACL reconstruction replicates the normal anatomy, it restores the normal kinematics and protects the long-term knee health. So we present a case of a 24-year-old male who presented to us with a twisting injury of his right knee while playing football. And since then he was complaining of pain and instability and with repeated episodes of locking. The clinical examination showed Latchman test to be positive. There was medial joint line tenderness. The McMurray's test was also positive, and the knee was locked in 10 degrees of flexion. The collaterals and the PCL were normal. The MR imaging confirms the ACL tear as well as a bucket handle tear of the medial meniscus. Now we proceeded with the arthroscopy of this patient, and you can see that this ACL is completely torn. This torn ACL was debrided in order that we make space for the new ACL. So when we are making double bundle, we need to make two tunnels in the tibia and two tunnels in the femur, and they have to be anatomical. There is very little margin of error while making these tunnels. So as you can see in this case, they are both these tunnels which have been drilled, they are covering the footprint of the ACL. Similarly, now we'll be making two tunnels on the femoral side. The first, the AM tunnel, is made about 5 to 7 millimeters in front of the over the top position and below the residence ridge. So this is the drilling of the AM tunnel being done, and according to the diameter of the graft, this is further reamed to the desired length. Now using a 5 millimeter offset to drill the PL tunnel, and in the same way, according to the depth of the tunnel, it is reamed to the desired length. Now you can appreciate that there are now two tunnels, the AM and the PL, which are in position, and now we are ready to pass the graft. For this, first we pass the fiber wire through the PL tunnel using a bead pin, and this fiber wire is retrieved from the PL tunnel on the tibial side, and then this graft is railroaded over this fiber wire. You can see the graft, this is the button, and now the graft is being pulled up in the tunnel. So this is the PL graft. As you can see, it is gradually being pulled up. So the margin of error while doing a double bundle ACL is very minimal, because you have to accommodate two tunnels in a very small place. Now similarly, the AM tunnel we have already reamed, and this graft is being passed in the AM tunnel now. The same steps are being repeated. The button is being passed through the tunnel and the graft is gradually pulled up. So we are gradually pulling up. This is the graft. So in addition, on the AM side, we use a internal bracing fiber tab to further supplement our fixation, and as you can see, on full extension there is no impingement. The grafts are parallel to each other in extension and cross each other in flexion, thereby meaning that the tunnels are anatomical. So this is the post-operative CT scan, which we often do to just to confirm our tunnels, and all these tunnels are anatomical, as can be appreciated on these CT scans. And the post-operative MRI also shows that there is incorporation of the graft. The ACL can be very well visualized on this 18th month. Both the bundles, the AM and the PL, can be appreciated on this MRI. Again, this follow-up also, this patient also had a bucket handle tear of the medial meniscus, and it shows a normal healing of the meniscus also. So this is a 15 months follow-up. As you can see, this patient is in the gym and he can perform all high-level activities. So we follow a supervised rehabilitation program for each patient, which is individualized according to the needs and which ensures that the patient returns back to his or her pre-injury level. Thank you very much for your kind attention.